Okay. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to respected Prof, doctors and colleagues. Thank you to Prof Iza for the kind introduction. So before I start my sharing, I would like to wish everyone Selamat Hari Raya and Ma'azai Batin. I hope we all are slowly getting back into our working mode, although maybe some of us stay in Raya mode. Okay. So today I will share my research with my MMed nuclear medicine student on the title of Efficacy of LowDose radioactive iodine-131, specifically 30 MCI in low and intermediate risk group of differentiated thyroid carcinoma. So this is my outline of presentation. So before we start, actually thyroid carcinoma can be broadly classified into 4 categories, which is first is differentiated thyroid carcinoma, where I will share today. So differentiated thyroid carcinoma consists of papillary and follicular thyroid carcinoma. And second one is polydifferentiated carcinoma. And third one is anaplastic thyroid carcinoma. And lastly, medullary carcinoma. So anaplastic and medullary thyroid carcinoma are non-iodine-avid disease. And these two types of thyroid carcinoma are treated by oncology team. So our team, we treat the differentiated thyroid carcinoma because it is an iodine-avid disease. So 90% of all thyroid cancer cases are from the DTC. So another 10% is from the other types of thyroid cancer. So other types of thyroid cancer. So PTC has the most prevalent subtype with excellent prognosis. Okay, the standard treatment of DTC is surgery and followed by radioactive iodine RI. So these treatment are recommended by ATA guideline, which is American Thyroid Association, and the National Comprehensive Cancer Network guidelines. So why we need to give RI to these patients? So post-surgery, patient undergo total thyroidectomy and near total thyroidectomy. So the surgeon unable to remove all the thyroid tissue. So this RI function as the radioactive who will eliminate all the residual thyroid tissue. And this is to further reduce the risk of recurrence in future. Okay, so the RI dose or amount are administered based on the risk stratification using ATA guideline 2015. So we stratify the patient according to low risk, intermediate risk, and high risk. So these stratification are based on HPE, histopathology report, post-IUD imaging, and TG level. So some history of on iodine. So this iodine already been used since early 1940s to treat hyperthyroidism, and then is expanded use in the thyroid carcinoma. Okay. However, since the past 2 decades, there is increasing concern on overtreatment of radioactive iodine, especially in low risk patients. So there is also increasing concern on the potential side effect of the radioactive into the salivary gland toxicity and secondary malignancy such as bladder cancer because of the radiation accumulation in the excretory organs. So there are 2 landmark studies which is HILO and Estimable 1, which demonstrated low dose RI are able to achieve ablation success rates comparable to high dose RI in low risk patients, with reduced treatment-related side effect and increase the quality of life of patients. So in 2015, it already provide a new guideline where the low risk are not routinely recommended to give any RI, but 30 MSI is acceptable for remnant ablation. So the question now is, are we treating too much, or our patient receive overdose, or our patient receive overdose of RI? So in Malaysia, other nuclear med center in major practice, they usually give RI dose of 80 to 150, depending on the risk of patient. Where low risk patient will receive 80 MCI, intermediate risk patient will receive 100 MCI, and high risk patient will receive 150 MCI. However, in USM, we have already adopted 30 MCI low dose since 2015. This is mainly due to our limited isolation beds and also our patient problem, mainly of the financial and logistical constraint. So importantly, a patient will receive 30 MCI does not require admission, and which we help to avoid treatment delays, and we reduce overall cost compared to high dose. Okay. So however, we have certain uncertainties in our treatment, especially the role of tumor characteristic, where such as capsular invasion, whether there is a present or absent of capsular invasion, vascular invasion, or lymphovascular invasion, whether these tumor characteristic will influence our treatment outcomes. Okay. So other uncertainties are the value of the post-op TG. Whether this TG can be a tumor marker post operation in predicting the success of RI therapy, and also the optimal timing in giving RI post surgery. So our study evaluate the effectiveness of low dose RI in Malaysian population. It's also examine the role of the TG levels, the tumor characteristic, and the impact of treatment timing that will influence the outcome of the RI treatment. So this study actually are relevant to our center as we have limited resources. We have a limited bed. We only have 2 rooms with 2 beds, and most of our patients have financial issues. Because of the cost, the higher the dose, the higher the cost. Okay. So our main objective is to assess the efficacy of low-dose RI in treating low and intermediate risk DTC. So secondary objective are to include to evaluate the demographic factors, tumor characteristic, TG levels, and also the timing of the RI in relation to the treatment success. So the benefit of study is similar with the significance of the study. So this study will provide us the guidance in assessing the effectiveness of 30 MSI in low dose RI for low risk and intermediate risk. So others are to support affordable outpatient management in a limited resource setting. So it also will guide us in personalized management or individualized management of patient. And also to assess uh, the time gap that we need to give the RI post surgery. So this is a methodology of our study. This is a retrospective study conducted in HPUSM from 2016 to 2022. So we include low risk and intermediate risk patients who receive 30 MCI. So the outcome of the study, we assess the success group, where the success group is also we call as complete response, where we assess the stimulated TG. The stimulated TG must be less than 1 nanogram per milliliter and negative in whole body scan. So this is an example of a scan that a patient has achieved a complete response or success of treatment. So this is the initial therapy. A patient receive RI, 30 MCI post-surgery. So we can see here that there is uptake in the neck. Because as I mentioned before, surgeon not able to remove all the residual thyroid tissue. So this iodine will be uptake by the residual thyroid tissue. So will be uptake in the neck. So here we can see the TSH stimulated is more than 30 and the TG is 1.44. So at least after 6 months of therapy, patient will receive a diagnostic RI, diagnostic iodine with 5 MCI. For the diagnostic purpose. So here we can see that the uptake in the net is already not there. So it means that the patient already respond to treatment, and then there also no abnormal uptake as well in the body. So the simulated TG also reduced in trend from 1.44 to 0.12. So this one we consider as a success group or complete response because of negative whole body scan, and also the simulated TG is less than 1. So this is the methodology of our study. So this is inclusion criteria and this is exclusion criteria. So 151 patients were recruited in our study. However, only 1 to 3 patients who fulfill the inclusion criteria were included in the study. Another 18 patients were excluded because 11 patients have TSH is not simulated, where the TSH is less than 30, and 2 patients with a very high TG, where we consider as high risk, we exclude from the study, and 1 patient who without diagnostic or body scan after therapy, we also excluded from the from the study, and other 4 patients are aged less than 18 years old. So this one is the inclusion and exclusion criteria for this study. So for statistical test, we use chi-square, ANOVA, and Spearman correlation. So for the result and discussion, a total of 123 patients with low risk and intermediate risk DTC received 30 MSA were enrolled in this study. 96 patients are in the category of low risk group, and another 27 patients are in the intermediate risk group. So as I mentioned, the outcome we assess the success group and non-success group. So non-success group actually is when the patient have biochemical incomplete, where patient the diagnostic whole body scan is negative. However, the TG is more than 1. And for and for the structural incomplete, the patient have TG less than 1. However, there is still uptake in the diagnostic whole body scan. So based on this demographic data, our department, Nuclear Medicine Radiotherapy and Oncology department, serve as the primary center for RI treatment in the East Coast. So we received all the referral from Terengganu and some from the Pahang. So based on this demographic data, we divide age into 2 groups, less than 54 years old and above the 55 years old. This is because DTC is unique. Our staging is influenced by age compared to other cancer staging. Only DTC staging is based on age. So the cut of age is 55. So a patient less than 55 is categorized into only to stage 1 and stage 2. Even though patient already matched to lung or bones, patient stay under stage 2. So this reflect generally means that these patients, they have favorable good prognosis with 10 years survival rate of 90 to 95%, even though in the presence of metastasis. So in this study, we recruited 85% female patient. As information, the most prominent DTC is commonly in female compared to males. And PTC is more common compared to FTC. So we can see that PTC is comprised of 86% of the study compared to follicular thyroid of 40%. So these are the tumor characteristic that we assess, whether there is a present or absent of capsular invasion, vascular invasion, lipovascular invasion, aggressive histology, and lymph node metastasis. Actually, from our hypothesis, we anticipate that presence of tumor characteristic may influence the treatment outcome. So from our analysis, age was not statistically significant, where the p-value is 0.95. There is no difference in age group. So while gender was significantly associated with treatment response, where the p-value is 0.03, it shows that female has a much success rate compared to male. Where we can see this is the treatment response, complete response, where female has a higher success rate, 65.7% compared to males with 38.9%. So this finding align with study with Sugitani and Fujimoto, and also study by Cooper. So study by Cooper mentioned that a male gender is associated with poorer prognosis, including greater recurrence rates and a poorer response to treatment. So based on this finding, we can this gender-based difference help us to personalize treatment strategies mainly for male patients. So this is the correlation between histology types and treatment response. So we can see that PTC has a higher success rate, where the success rate is 66% compared to FTC only 35%. So these findings supported by Sugitani Fujimoto, Cooper, and Fogan. Okay, this one is a correction with suppressed TG. So actually post surgery, patient will require lifelong tyrosine replacement. So this tyrosine replacement, we suppress the TSH and we reduce the risk of recurrence. And this one we correlate with simulated TG. So this compared to suppressed TG, this suppressed TG taken post surgery. So this time patient are on tyrosine, and this one is patient we take the blood prior to RI, where patient need to withhold the tyrosine at least for 1 month. So in summary, these both stimulated TG and suppressed TG showed no significant association with treatment outcome. However, study by Romero et al. Show that if patient have stimulated TG more than 10, it will be associated with recurrence. And anti-TG antibody can interfere with TG interpretation. That's why we exclude from our analysis if the patient have anti-TG antibody positive. So this is a correlation between tumor characteristic and treatment response. From our study, there's no significant association between all the tumor characteristic. It is mainly because of the small sample size in this subgroup. If you can see that all the subgroup, we have only a small amount of samples. So this is a correlation between timing of RI post surgery and the treatment response. So we can see that most of our patients receive RI less than 6 months, within 6 months. And another, we receive the RI within 6 to 1 year. So from this analysis, we can see that mean gap in non-success group is 150 days and in success group in 154 days. And there's no significant impact on the RRI success. So this analysis also supported by Suman and Sirona et al. So from this analysis, there is no substantial evidence to suggest that the time gap between post-operation and RRI has a significant effect on the treatment success. Okay, this is correlation between success and comparative study. So from our study, low risk have 63.5% success, while intermediate risk have 55.6% success. Although we anticipate it's more higher percentage compared to this from our finding. However, this finding is comparable to Hilo, Agai, and Segla and Fatima finding. And then they show that there's no significant difference in success between the risk group. In summary, low-dose RI showed modest efficacy with 63.5% in low-risk group and 55.6% intermediate risk group. So we need to individualize approach essential for the intermediate risk group. And for the treatment success, it's more success in higher success is more common in females and PTC compared to males and FTC. And the RI timing within 6 months post-surgery is acceptable. And tumor characteristic and TG level were not predictive for the RI success. However, in our study, we are there's few study limitation because it's a single center data, which limit the generalizability of this study. And short follow-up period may not capture the recurrence post diagnostic whole body scan. And small number of cases with northern mets and aggressive histology may reduce the statistical power of this study. So our recommendation for the study, after this study, we consider 30 MSI low dose as a safe and cost-effective option for low risk and intermediate risk in selected intermediate risk. Future studies should include longer follow-up to assess recurrence. And we need to investigate new biomarkers such as BRAF 600s to improve prediction of treatment outcomes, and larger sample size needed to validate the finding. So our study is based on ATA guideline in 2015. So ATA guideline already produced a new guideline in 2025. So actually our study is aligned with the ATA 2025 direction as it evaluates the role of low dose RI and question the necessity of higher dose. So particularly intermediate risk. So actually in ATA 2025, they already recommended that no RI needed for low risk patient. So the key shift from ATA 2015 to ATA to 2025 is the move from a static initial risk-based approach to a dynamic response-driven and more personalized management strategy. So finally, I would like to thank my student, Dr. Muhammad Azizo, for his research and our team from Unit Nuclear Medicine. With that, thank you for your attention.
Okay, so thank you, Dr. Wan Fatihah, for sharing your nice research presentation with us. Now, I would like to probably allow one or two burning questions, especially either from the audience or also from the judges. We have one or two questions in the chat box. Probably I'll just read the first question just to make the session more stimulating. So we have one question from Prof. Azlan Hussein. Any reason why low-dose radioiodine is not well practiced in Malaysia, as it is well recommended by international guideline? Is it because of the issues in accurate classification between low or intermediate risk differentiated thyroid cancer versus others? The one?
Thank you, Prof. Azlan, for the questions. So actually, as I mentioned, most centers still didn't practice low dose RI. Just a few centers such as in Queens, in Sarawak GH, they practice a low dose, especially in patients with financial constraint. However, in other center, I'm not sure why they still not practice this kind of low dose treatment to low risk patients. For question number 2, how is our treatment response rate? So in comparison with other study, because this is a low risk, so our findings is comparable with other study. However, their success rate is much higher compared to us. So the third question is, what is the acceptable median follow-up to determine the long-term treatment response? So actually, according to guidelines, for low risk patient, patient need to have a yearly TG at least 3 to 5 years post diagnosis, post complete response. So at least in low risk patient, at least a patient need to have a yearly follow up for at least 5 years. So that's why because our patient in our center already we have a lot of patients. So most of the patients we already sent to the primary center to evaluate the TG levels. However, in most of our nearby center, do not have the facility to assess the TG level. They need to send to Gribbles or I think somewhere in Penang to assess the TG level. Mainly in follow-up, they need to assess the TG level. So another question by Prof. Maya. Is it due to our patient are more likely to default? Is it this question is according to maybe the first question by Prof. Azlan. Maybe as in some center because such as in IKN, when patient was referred to their center, patient come from anywhere in Malaysia, from Johor, from Pahang, from Melaka. Maybe there is the aim of treatment. They want to uh, ablate. They want to eliminate all the thyroid tissue in um, in just a short period. It means that patient don't need to come a few times for treatment. So that's why they give high dose to patient. So when they treat the patient, the treatment is the aim of treatment is to absolutely eliminate all the residual thyroid tissue. Although the recommendation by 88 guidelines, even in 88 2015 and 88 2025, already recommended low dose or no need for RI for low risk patient.